feeling like sunshine, like springtime, like something's in the water and I'm taking a deep dive. I'm feeling so weightless, like I'm gonna make it, and nothing in the universe can take this. I can see it clearly now, nothing gonna bring me down. I got my head held high, I'm on my way, and I'm following the signs to my happy place. I'm walking in the light of a brand new day, and I'm right where I belong in my happy place. I got my head held high, I'm on my way, and I'm following the signs to my happy place. I'm walking in the light of a brand new day, and I'm right where I belong in my happy place. And I'm right where I belong in my happy place. And I'm right where I belong in my happy place.
Welcome to the National University of Singapore Yonglulin School of Medicine Healthy Longevity webinar. It's a great honor having you with us tonight. We are going digital. Professor Dean Ho will talk about the interface of digital medicine and longevity medicine. Please leave all your comments, your questions, and whatever in the chat box. We will have a look at it. Our short presentation today will be given by Casey J, our PhD student at the National University of Singapore. She will present the findings of the Diet and Healthy Aging Cohort study and talk about nutrition, especially about the malnutrition risk in older adults. Casey.
Thank you for the kind introduction. As mentioned, my name is Casey, and today I'm very honored to present to you one of my published papers titled Adequacy of Nutrient Intake and Malnutrition Risk in Older Adults, Findings from the Diet and Healthy Aging Cohort Study. As we all know, the older population represents the largest demographic group at risk of malnutrition. In the community, malnutrition among older adults are often left unrecognized until pronounced physical changes are apparent. Therefore, screening and identifying nutritional problems among older adults is of utmost importance. Early detection will not only allow public health professionals to address nutritional problems at its earliest stage, but also prevent future incidents of nutritional problems. The aim of this study was to report on the nutrient intake and prevalence of malnutrition risk in a community sample of older adults in Singapore. We used the Diet and Healthy Aging Cohort, which recruited 1,060 community dwelling Singaporeans or permanent residents aged 60 and above. The study was conducted in person at our research site, and data was collected by research assistants using structured questionnaires. During the interview session, we collected dietary information using a validated food frequency questionnaire and screened for malnutrition risk using the NSI determined checklist. We also asked questions on dietary practices and assessed nutritional knowledge among older adults to understand health behaviors related to the nutrient intakes. Using available data from 738 participants, we found that the majority of older adults met the recommended intakes for energy, protein, total fat, carbohydrate, vitamin A, vitamin C, iron, and were within the limits for cholesterol. However, the older adults did not meet the recommended intakes for polyunsaturated fat, monounsaturated fat, dietary fiber, and calcium, and had excessive consumption of saturated fat and sugar. It was found that people mostly use olive oil and canola oil, which are monounsaturated oil for cooking, followed by corn oil and sunflower oil, which are polyunsaturated oil. When having beverages, older adults more often use creamers and sweetened condensed milk, while 46% will still ask for less sugar or less sweet options when ordering beverages or desserts. In the nutritional knowledge test, more than 50% of participants were in the higher score range, with 38% scored moderate in nutritional knowledge. When asked about whether they pay attention to dietary and nutritional information, almost 50% reported that they always pay attention to dietary and nutritional information, followed by 34% who sometimes pay and 14% will seldomly pay. When participants were asked about their most important source of nutritional information, the top 3 answers were media sources, relatives and friends, and health professionals. It was found that 16% of older adults were at moderate nutritional risk, and 6.4% were at high nutritional risk. Based on the answers to the checklist items, we could see that some common problems older adults have include having an illness or condition that made them change their diet. Eating alone most of the time is also a common problem. And out of all, taking 3 or more different drugs a day was seen in almost 1/3 of the participants. All these are risk factors for malnutrition. In conclusion, nutritional advice for older adults should focus on eating nutrient-dense food, especially foods rich in calcium and dietary fiber, and reduce saturated fat and sugar intake. Given the important role of calcium in bone health, screening for calcium deficiency should be part of the routine health checkup, along with nutritional education on the importance of calcium in a healthy, balanced diet. Overall, the findings will facilitate decision-making by health promoters to deliver targeted nutritional care programs in this growing segment of the population. To end this, I would like to acknowledge my supervisor, Dr. Feng, Prof Lee, and Dr. Lim, and support from the community parties. Thank you all for your attention.
Thank you, Casey, really highlighting how important diet is and how important it is to really prevent malnutrition. Maybe we are talking a little bit about the diet. We are talking about digital longevity medicine. Professor Dean Ho is with us. He is the Provost Chair, Director of the Institute for Digital Medicine at the Yonglulin School of Medicine. He is also the Director of the NS1 Institute for Health, and it's not enough. He is also the head of the Department of Biomedical Engineering at the National University of Singapore. Professor Ho, Dean authored not only an incredible amount of journal articles, but also co-authored quite recently the best-selling book, Medicine Without Meds. He really was featured everywhere in the Straits Times, TNA, National Geographic, CNN, The Economist, etc., etc. He has great presentation techniques, and I can tell because I saw him on the stage several times. He's just an inspiring personality. So, Dean, it's such an honor to have you here on our webinar tonight. I think we will learn a lot how longevity medicine, which is already a very, very early stage medicine subspecialty, how we can even go further and how we can go digital. Thank you for being here.
Thank you so much for having me. Congratulations, Professor Andrea, for all the successes with the initiative and, again, this very important field and your work in advancing the community towards a prosperous and healthy future for longevity. So thank you so much for having me. I wanted to thank everybody for joining today from wherever you are for a discussion that we're going to have about how we're harnessing digital platforms to look at potentially the future of longevity medicine. And so with that, I'm going to jump right in and share a little bit about what we're doing at our institute. I'm going to start things off today with some of the initial work that we did in how we view individuals, whether they're patients or whether they're healthy subjects, and how we're harnessing technology to dynamically personalize everything from intervention for patients all the way to potentially lifestyle modifications for healthy subjects. So I think one of the key lessons that I want to talk about today is that people, be it patients or healthy people, should be treated as stories over snapshots. I think when we think about how even some of our own healthcare has been administered, we sometimes rely on a single blood test. We rely on a single reading, a single marker, or maybe just a couple of markers. And from that singular point in time, we use that to guide our care, sometimes long term. And I think what we've seen with our own technology, people really should be treated as stories, because not only do we know that we're different from each other, but it's important to note that we are different from ourselves over time. And so it's important, whatever the intervention is, whether it's a dietary intervention, a fitness intervention, or a therapeutic or a pharmacologic intervention, it's important for that intervention to evolve alongside the subject as they undergo treatment. So stories over snapshots is a recurring theme that I'm going to talk about today. I'm going to kick things off with one of our first technologies that we developed known as Curate AI. And about 10 years ago, we had proposed to the clinical community that people evolve over time and that doses, for example, for drugs may also need to evolve over time. The challenge is when we think about the word optimization, that term means different things to different people. And 10 years ago, when we thought about the notion of dynamically optimizing doses, which means dynamically changing them for people, the challenge is in traditional healthcare, optimization means escalation. It means trying to find the highest possible dose one can get, and especially in the field of oncology, we were met with this very simple answer: no way. We will never do that, because in oncology, dose changes, which would pretty much only go downward because patients are given the max tolerated dose usually, dose changes are guided by toxicity, right? Makes sense. People come in and get a max tolerated dose, and if it's not tolerable, they'll drop the dose based on tox. But we had proposed this notion that especially in combination therapy, that maybe transiently lower doses can work better for patients. So I'm going to guide everybody through a couple of examples here, lessons learned. So I'm going to start with a patient story, patient number one, when options run out. A few years ago, we were presented with a patient who had approached us who had stage 4 prostate cancer. And this patient, the cancer had metastasized to the bone. This patient was being given a 2-drug regimen, and the regimen was no longer tolerable. The patient was entertaining and thinking about stoppage of care with just a little bit of data. And the data that we need doesn't rely on population data. We use only a person's own data to modulate only their own care, right? So this is small data. And one can argue we have no data when the patient walks in. We actually look at how the patient responds through their biomarkers to variable doses. And so this is kind of this longitudinal stories over snapshot platform that we use and understand at variable doses, how does this patient respond? And using that very small amount of information, we craft what you see on the left here, a digital avatar for this patient, only using their own data. With this avatar, we were able to recommend a dose reduction of about 50% for this patient to increase efficacy, right? If you look at the axes, it's about dropping the PSA, which was their marker. And at the time, the clinicians were not okay with this. They said, look, in oncology, we don't change doses based on efficacy. And we certainly don't drop them 50% with the notion of improving efficacy. But at this point, the patient had no other options, signed the waivers. We got the approval to drop this dose. And within a week of that dose drop, the patient's cancer markers were the lowest they had ever seen during the course of treatment. During the course of continued therapy, we started to modulate the dose, never going above max tolerated dose, but really kind of dynamically adjusting these doses to sustain and enable a durable response. So what this told us at the time was that especially with chemotherapy and targeted therapies, brute force isn't always best, and sometimes less is more. And we've started to see this occur in other use cases as well. I'm going to run through just a couple more. Was another patient here in Singapore who had stage 4 gastric cancer. And as we know, it's a devastating illness with a very low 5-year survival rate. And with this particular patient, every time this patient was administered a treatment, the patient was readmitted into the hospital due to acute liver failure. And it came upon a point where the patient was at a stage of undergoing no more care. It would be end of treatment. But the patient still wanted to try some more options. And so we used Curate to modulate and start the patient at a lower dose. And at a lower dose, very similar to the previous patient, we not only saw a response and a cavitation of the tumor from the patient, but they no longer needed to be readmitted. The quality of life had improved. And not only was the outcome positive, we were able to look at the health economics of this patient. And by reducing the dose of an expensive drug and also looking at the elimination of constant readmission into the hospital, we were saving both the patient and the healthcare system substantial money by improving these treatment outcomes. And so what this tells us is, under the standard guidelines of max dose, humans in situations are unique, right? Not all problems have the same solution. Another recurring theme. Final patient I'm going to talk about is the story of patient 3. Sometimes trying something different to overcome big challenges. We were not long ago presented with a patient with a rare cancer and was encountering some challenges with their treatment. And suffice it to say, we were able to kind of calibrate this patient using Curate, and you can see kind of over time, this patient's profile would evolve. I'm going to skip to the end here. This patient has had a stable disease due to the reduced dosing that we recommended now and continuing for over 28 straight months. Right. And so in this particular case, I want to indicate that our goal is not to low dose all cancer patients. Our goal is to allow each patient to see a broader range of doses and exposures to find more responders. Right. So again, not trying to low dose everybody. It's really about dynamically letting each user see a broader range of doses to make sure we're finding the right dose at the right time and using only their own data, right, to dynamically address their care. So for us, personalized medicine, personalized intervention is dynamic. Patients differ from themselves over time. Right. And I think this is something that we want to take home from today, because there are a lot of different definitions of precision and personalized. And I want to indicate that we're not all or none, right? Using Curate, I think we have a platform that can be slotted into these clinical workflows where we still very much need the big data community, the precision medicine community, because it's this community that can help recommend to us which drugs to even start with in the first place. After that comes into play and we know which drugs to think about, we're very complementary to these big data approaches so that we can then take it from there and start to think about how we can adjust true N of 1 medicine using, again, only a person's own data for their own care. I think what we've seen over the past few years is our ability for our innovation to expand beyond technology and move towards policy as well as education. This past summer, our Curate AI workflow was published in the ASCO educational book. And for those who don't know what ASCO is, it's the American Society of Clinical Oncology. And their educational book is the cornerstone resource for the education of clinical oncologists worldwide. And so it was a rewarding moment for our team where 10 years ago we were told no way. And now we're seeing this workflow appearing in the Ed book. I think it's a great testament to the community that we have in Singapore and at NUS to bridge ideation with deployment and validation. Our work has subsequently been featured in the WHO guidance on the regulation of AI for health. And then not too long ago, I had a chance to speak at an FDA ASCO dose optimization meeting alongside FDA officials, leading clinicians, as well as pharma, to think about how we're doing things a little bit differently here in Singapore. And by treating the individual as a story over snapshots, it's actually allowed us to rethink how we design clinical trials. And so it's been an exciting time for us. And so I really want to stress how dynamic we are as people. And so I wanted to take this chance to maybe share a personal journey in digital health. And we are the Institute for Digital Medicine after all. And I think many of you out there have taken your own personal journeys in using different gadgets and finding different ways to understand how you respond to different types of interventions, be it dietary, be it fitness, be it sleep, be it supplements. And again, no two people are alike. And again, we are not even like ourselves over time. So I wanted to kick things off by maybe telling everybody a little bit about what I do for myself. And I want to reemphasize that no two people are alike. And I think there is no real fixed one-size-fits-all regimen. I do want to add that this was done under medical supervision. And again, it's important to remember that. And I'm going to kind of dive right into some of the things that I do for myself. For the past many years, I've practiced intermittent fasting, and even my regimens there have changed over time. I did not start out doing this many years ago. I started out with multiple square meals a day, maybe not the healthiest breakfast, and through small habit changes, I started to gradually kick out the sugar from my coffee, to kick out other things that I put in my coffee, like milk, etc. Again, nothing against it. It's just something that I wanted to do for myself. And then over time, I started looking at the 16-8 regimen, which many of you may know. And because I really like to exercise in the morning, I tended to kind of eliminate breakfast, except for maybe a little bit of coffee and some water. And then start with lunch and dinner. And then over time, I started to push lunch backward until eventually I had this kind of somewhat of an OMAD, or a one meal a day type regimen. And I'm relatively quite consistent with that actually these days. But we got to know our limits. And the reason we have to know our limits is because I do work out consistently every day at 7 a.m. My workout emphasizes strength about 5 days a week. I do intense cardio, hills, sprints, runs for the other 2 days. And to sustain that, I sometimes tune my fasting regimens to make sure I don't overdo it. Again, we all change over time. It's important for me that when I undertake this regimen, I don't eventually kind of start sacrificing sleep, right? We know ourselves the best. Food. I think food and nutrition is critical. While the windows of eating are short, I think it's important that we eat as well as we can. And in a very summed up snapshot of what I do, it's green and lean, right? And I'll show a little sample of that in just a little bit. I think for me, I like eating actual food. And again, not taking away from what anybody else does, but I think this works well for me, so I can sustain this regimen. I will add that I'm not a rigorous calorie counter, but I do track performance. And performance includes sleep as well, not just strength, run times, and things like that. Right? I think the power of data matters. The right is a mosaic of just a sampling of various types of data I collect for myself, everything from BP to weight to grip strength, actual performance of my runs, of my lifts. I do monitor my food. I, again, don't enter calories because at the end of it all, it's about behavior, right? We take our technology, we're really interested in technology at our institute, but we also recognize that at the end of the day, it's behavior that matters, whether it's the user that continues to use the technology we develop, and that user can be a clinician, right? It can be an actual patient. It can be their caregiver. And for me, it was a journey also in understanding how to maintain adherence and how to guide my own behavior to stick with regimens, and how, for me, my data plays a role in that and in motivating me. I've used all kinds of devices, as I'm sure many of you have as well, from continuous glucose monitors to ketone strips, et cetera, and I'll get into that. I like using CGM, not so much for monitoring dietary, even though I can do that, but I don't eat a ton of carbs, but I do use it to look at glycogen depletion. And when I look at my workouts, it's really fun for me to see spikes when I'm doing my strength training. It's kind of like instant gratification, instant feedback for me to see what I'm up to, right? And so when we look at, among other things, I look at my ketones, but not just to see if I'm metabolically switching from sugar to fat burning, but I'm really interested in my ketone dynamics. I know that there's some new technology out there for wearable continuous ketone monitoring. I still stick with blood ketone monitoring. So people ask me all the time, how is it that I can stick my fingers 10 times a day? And for me, again, this is to each their own. The data to me is more interesting than the very transient pain I get from sticking my fingers. So that's just me, right? And again, done under medical supervision. I wanted to quickly highlight this graph here. when I started this exercise, I did notice that, because I eat my one meal later in the day, about 5 o'clock onwards, that in the mornings when I collect my ketones, which are in blue, my ketones are high. And I work out at 7 a.m. And so right after I collect my ketones, I go work out. And when I work out, I can see my glucose go up due to glycogen depletion. And then I come back after the workout, I take my ketones, and my ketones bottom out because we've had sugar in the system. And then as I continue on with the day, my ketones rebound. And I have this kind of elasticity here, this dynamic. And I thought that was pretty cool. And then I break my fast after that. And then day by day, I would try to, I would see this curve constantly reappear. But again, my goal here is not to stay in ketosis in perpetuity. I kind of kick myself out when I feel like it. And I like to see how quickly this kind of trajectory disappears. And then sometimes when I feel like it, I go back and I try to see how long it takes to kick myself back in via this metabolic switching process. And I've had some really cool discussions with clinicians who study metabolic switching and how kind of the ability to metabolically switch changes over time. And I'm certainly interested in learning more about kind of what type of potential cardio and neuroprotective effects we may have as we undergo this switching process over time, right? And for me, what really happened was this data. I didn't realize that my own data, and especially the movement of that data over time, would become sort of some kind of self-gamification, if you will, right? And so when I fast, I look at the dynamics. And just in case for those who are not familiar with this device, it's an Optium Neo, and this includes both my glucose and my ketones, by the way. I don't want anybody to be alarmed when you see a 0.5, that's my ketones. That is not my glucose, right? The fact that I'm sitting here today will confirm that. Fitness, again, I just threw this example up of some grip strength monitoring. And that's something that I do regularly. I do it normalized, right, left hand. I monitor my lifts. I monitor my strength progress. And again, certainly my run times, heart rate variability, VO2, et cetera. I do bloods during my longer fasts. I do my before and afters. I look at various markers from your standard cholesterol panel all the way to other markers, to your ApoBs, ApoA1s, and I'm always open to looking at more as well. Just a little bit of insight into what I eat. I call it green and lean. Anybody interested? Everything from certainly greens, as you'll see, to some healthy fats, from pecans and macadamias all the way to chia seed, and certainly I eat a lot of chicken. Again, to each their own. Various diets work best for people to sustain their performance, and this one works for me. And importantly, it's actually just sustainable for me. And I eat a lot. I eat eggs as well. As I kind of move towards the end of this talk, what you look here on the left, I won't get into it in great detail, but it's kind of like this kind of continuous gamification of sustaining ketosis for a designated period of time. I knew I was going to kick myself out, but I just wanted to note that during this month-long period of time here, I actually traveled across the world. I traveled from Singapore to the East Coast in the US. I traveled from Singapore to Bali. And for me, it was an exercise in understanding not so much the monitoring, because it was routine for me, but how I was able to kind of work with the hotels I stayed at, the airlines I flew with, the restaurants I ate at, to kind of maintain the kind of dietary intervention that I wanted, and to make sure I was eating healthy and eating well, even with travel. And so that was a really fun experience. I actually integrated some fasting into my flying routes, and the airlines were super helpful with that. And along the way, again, there's some 72-hour fasting that I did, monitoring my blood pressure along the way. It's been a really fun exercise. And why, right? What are some things I'm actually looking to do with this? Well, we know we have Curate AI, and we know that we can dynamically modulate how to intervene to achieve a specific outcome that we want. And we've done this not only with drugs, right? Not only with cancer patients. We're doing this for hypertension. We are doing this for digital therapy, where the software is the intervention. By dynamically changing difficulty levels, we're looking at human physical performance optimization as well, be it exercise, all the way to cognitive performance. And for me, something I'm interested in is just selecting ketones as a marker. I was interested in understanding what combination of fitness duration, fitness type, and fasting duration could I see and modulate to drive faster switching, maybe without having to fast for a super long time. And so some things I've learned are, how different I behave when I do weights over cardio, even for the same duration. And I've actually found that in some cases with shorter fasts, but with a dictated regimen for strength, I'm actually able to switch pretty quickly, even when I'm fully carb loaded going into the switch. So it's actually been pretty cool looking at how I can dynamically tailor my own regimens to achieve certain outcomes. And why ketones? Doesn't have to be ketones, right? There are other markers we can look at, but this one was a quick one that I could monitor. And so it's really been a cool exercise in understanding how dynamic I am over time. And so learnings for me. For me, this journey was all about small habit changes in the beginning. And kind of learning how my own dynamics change over time, unbeknownst to me, became a gamification exercise. I'm actually finding new ways each day to use certain gadgets around me to kind of stay on these regimens. In fact, at this moment, I mentioned to the seminar crew here earlier, I'm right now about 45 hours fasted. And hopefully I've been coherent. Hopefully I've been awake, right? And so I seem to do okay. But for me, I learned that visualizing my data and also visualizing changes in my data over time were a great motivator for me to keep me interested in this process. Certainly, there's always room for more markers to monitor. And it's important for me to figure out, again, look for ways to figure out why am I doing this, right? What are some things I can modulate to find the right interventions for me to keep my performance on par? I wanted to reemphasize that this isn't for everybody, right? I think for those who are interested in fasting, for those who are fasting right now, it's not for everybody. And for those who, and certainly, when it comes to prediabetes and certainly for diabetics, clinical input and clinician input is essential. And then for those who do fast, I'm certainly not telling everybody should fast for 20 hours, 22 hours, 24 hours, 48 hours, 72 hours. It's really about what's of interest and what's safe for each person trying this. But for me, I found some really interesting data insights during the process. I wanted to thank everybody for having me. Again, congratulations, Andrea, for an amazing seminar series. Congratulations to the Healthy Longevity crew for the amazing work that you're doing. I'm always happy to stay in contact with everybody. I do post some of my learnings periodically on the socials. And in the near future, we're going to have a preprint coming up of some of these learnings as well. So with that, thank you so much, everybody. I know everybody's tuning in at different times around the world. Really great talking to everybody. Now happy to answer some questions. Thank you.
Thank you, Dean. Fantastic to show your own data. So I know you are quite fit, but seeing also that even your glucose level is changing over time. May I ask you the first quite personal question? Are you a spiker, a glucose spiker or not?
Good question. No. So the axes are a bit condensed. My glucose, my A1C, for those curious, because that's going to show up in the preprint, is about 4.8. And we put that up there. So I haven't yet done much experimentation, although that's on the way. I think people post a lot about this online where people consume certain food products. Yep. And then they consume something that would normally spike their glucose and see what happens. I'm gonna do one of those a little bit later. But I inherently don't consume a lot of carbs. And in cases where the dietary increase goes up past 6, I'm probably downing a bowl of rolled oats, or I feel like I've earned a big bowl of noodles or something that day. But typically speaking, I'm well within range. And my A1C, which we post in the preprint, is 4.8.
Okay. Yeah. let's get a little bit towards the health longevity medicine arena. As you might know, health longevity medicine is really optimizing health and health span by antagonizing aging processes across the lifespan. You mentioned, I think, a couple of times in your talk, you would like to optimize individuals and optimize the interventions you are giving to individuals. How do you define optimal?
That's a great question, and I think that that would depend on, say, the indication, right? I think something I thought about showing today, which I didn't, is back in the day, my team and with collaborators we were looking at fatty liver disease because it's certainly an issue that's very prevalent in our region. And a lot of the drugs just weren't successful in the clinic. And from a prevention standpoint, knowing how much of the population here would go through this and knowing how much of a driver FLD is for liver cancer now, we went to work looking at supplements. And so with supplements and with the preclinical models, there are very clear readouts that we can look at in terms of, the histology and the markers. And so a lot of interesting things we found during that optimization process is we have a very quantifiable outcome there. And looking at a pool of 5, 6, 7, 8 natural compounds that were accessible, easily accessible, and that could be formulated together, optimum to us means which agents do you combine at what specific dose ratio to reach the very best possible quantifiable output you can get. Given a specific pool of 8 to 10 agents, the optimum doesn't mean it's going to be 100%. But to know that you are actually reaching maybe the optimum is you're ever going to get is 80% suppression. But to find that 80%, you have to know the galaxy of possibilities, right? And that's what a different platform that we have, and working with Professor Ed Chow, a different platform that we have does that with a small number of actual experiments. It's not purely computational. With a small number of actual experiments, we can really interrogate the galaxy of possible permutations in a few weeks versus 1,000 years, right? When you're looking at a 10 to 12 to 15 pool of candidates to try out, that could be 1 trillion possible combinations. So for us, the optimum is whatever quantifiable metric there is. That's from the context of combination design. From a standpoint of individualizing treatment, we'll need a marker. In the context of cardiology, it could be hypertension. In the context of aging, I think what's going to be really important now is to speak to the clinicians, such as yourself, and to say, when we're looking at a person and we want to optimize some type of endpoint for them, what is it that you want to see happen? And then if you have some type of endpoint we can use that we change over time, and our goal is either to maximize it or to minimize it, then we look for the interventions with your guidance. What are the interventions we want to try to modulate and to optimize? And then when that happens, as we calibrate the user, we'll start to kind of see what boundaries each patient has. So then from there, we can start to either drive down or drive up. But again, it depends. I think if soon we have a holistic marker, or if we default to a specific marker for something, we're agnostic. We're actually agnostic to that.
Can you actually predict the optimal outcome of an individual? And if yes, how could you do that before actually perturbating it?
So that's a great question.
Genetics, epigenetics. So can you, based on the input you have, predict?
That's a great question. I think that if we're going to use true optimum as our benchmark, I think what's going to happen, at least from our standpoint, from our technology, that is we would need to, and you're exactly right, we would need the calibration, the perturbation. Even though we don't need big data to do what we do, at some point, our goal is to generate big data. From the generation of big data, and using kind of this, right now, when we look at clinical data, if we step away from longevity for a moment, we look at all the clinical data that's been collected, there's very few indications where we have data on the same person seeing variable doses and longitudinally tracked markers. Transplant, yes, but that marker is actually PK. It's not an actual marker for immunosuppression. And we know this because for all the indications we've done, when we ask our partners, it's very clear to us. Yes, we'll have some people who get this dose, some people who get this dose, some people who get that dose, but not one person that's seen it all. I think a very important and awesome opportunity for the longevity field is to build new data sets where people have, you have data sets where it's a specific person seeing a range of perturbations accompanying the longitudinal readouts. Once we build that data set, we have actual broad exposure per person as the benchmark, then we will get subgroups. There are definitely going to be subgroups that emerge. And when the subgroups emerge, then we can look at the profiles of those people to predict, and with those subgroups, predict who is likely to have more or less success under a type of intervention. I think if we look at transplant as an example, there's like starting doses, right? Different genders, ethnicities are assigned starting doses. Those are based off of population averages, not optimized data. For longevity, if we can build these optimized data sets, sky's the limit.
Agree. So we are really looking forward to first implement the precision healthy longevity medicine, and then the precision is the NS1, and then it's personalized.
There you go.
Yes.
We're going to work together on that.
Oh, yeah. Yeah. Beautiful. What would you advise healthy longevity medicine physicians who are claiming, or it's not a subspecialty in its own at this moment in time, where to start? Very often we already have a biological phenotype, a clinical phenotype, and also a digital phenotype. But this is the hardest because there needs to be an interface between the clinician and the actual user, and there needs to be the data to be shown to physicians. And very often this is not being done yet. What would you advise the clinicians in our field to actually ask for individual data of the patients? Because you seem to be a client of somebody, you do it under medical, you said medical supervision.
Yeah, I'll elaborate. No, you raise a great point. So my medical supervision is primarily kind of clinicians who are not longevity clinicians, but people who make sure that they're comfortable with me, licensed medical professionals signing off on multiple blood tests. And this is actually going to get to my answer. Multiple blood tests to make sure they're asking me the right questions, checking to make sure my kidney, liver, everything's okay as I undergo these long fasts, and to make sure they're kind of checking in to make sure there's no other issues that would prevent me from doing this. Certainly to make sure my blood sugar is okay, et cetera. But something that I did learn during this process, if I use my own data as an example, my very first blood test, the very first blood test I had, I had your standard panel. And from there, that panel was a summation of fasting, of working out, of et cetera, at the start of a 72-hour fast. And when I got that result, the doctor was like, okay, so based upon this result, this is what I would say. Maybe you're fine, but maybe, you're going to want to watch out for your diet. Okay. And I'm like, well, my numbers are pretty good. They're like, yeah, but you're getting older. And so you're going to watch out for consume less fat. Okay. And I'm like, but fat is a very general thing. What about healthy fats like pecans? They're like, pecans are like nuts. It's got fat. You should cut that out. I'm like, okay, food pyramid, the whole thing. And I'm like, isn't the food pyramid like, maybe I think we're thinking beyond that already. So they started with that. And then what happened was when I got my next blood test, the numbers actually plummeted. Okay, so it was actually a good thing. And the doctor was very puzzled. They're like, I don't think a 72-hour fast will do that. And I agreed, right? I was like, that's actually a pretty strong plummet. And then I had told them that I had this kind of OMAD plan, and they actually didn't know what that was. I explained I did fast before my first blood test, but maybe I do consume my calories in a later part of the day, which I think they realized you might need to take your blood test a little bit later in the day. Then we redid the whole thing continuously. And then I started. The numbers were fine. All the numbers were fine. Actually, just for those who are curious, my lipid panel, my ApoB, ApoA1, the ratios, etc., are better now than my 20s. Okay, so it's going well, but there's something interesting. My longitudinal data, unless I do it on my own, is not plotted at all. In fact, the way the EHR is working wherever I'm going, whenever I get a new blood test, it just replaces all the records of the other ones.
Yes.
And so one day I logged in, I'm like, oh, this is going to be cool. I'm going to see all my data, at least the record, and it's all the charts are the same chart, right? And so this may seem like a low-hanging fruit, but I do realize it's a step that probably would help, is if we can get more longitudinal plotting and trajectories plotted over time versus because to be fair, most people who are not in the longevity space probably get one blood test a year if they're lucky, okay, if they're diligent. Some people don't do it for 5 years at a time. But I think for the longevity field, the greatest strength of the field is the ability to kind of start thinking very longitudinally. And that's a galaxy of data that I think no field has. Well, I know for traditional medicine doesn't exist.
Yeah.
And so merging kind of these tests with longitudinal and then modulated input, it's going to be an amazing opportunity for machine learning as well.
Yeah. And especially if we have the digital phenotyping in there, it's all your behavior. And it's a pity because we have that in early stages of life.
Yes.
Look, we are tracking the development of babies and then infants, etc. Just continue doing that. Absolutely.
And it totally stops eventually. And now we have all these resources. We should keep it going.
Absolutely. Absolutely. I have so many questions, especially how to scale all of this. But I would love to first go to the wonderful questions of the audience. Wai-Han, our PhD student at the NUS at the School of Medicine, what are the questions of our audience?
Thank you, Prof. Andrea, and thank you for Prof. Dean Ho for your beautiful presentation. So we do have a lot of questions from our audience, and the first question I'll ask is about the digital medicine. So do you think the food dietary apps, which estimate the calorie from the analysis with computer vision AI, can help ameliorate this kind of malnutrition on seniors?
I think they can. That's a great question. And from the presentation that was really exciting before this, I think that's an area of concern, certainly. There's so many apps out there. I think that at a very basic level, there's typically going to be drift, okay, between these apps, obviously, and what's actually on the plate. But if the app is allowing the user to be more conscious about their dietary intake, because whether it's longevity, whether it's traditional medicine, or whether it's AI or anything under all of these umbrellas, I think education and awareness is an area that will always need to be raised. Give you an example, right? I've spoken with colleagues in the field from around the world. And I actually sometimes ask them a simple question. I ask, what type of cooking oil are you using in your home? Right. And the answers range from, I don't know, to this one because I thought it was good. And a lot of times something like that, I think there can be more awareness raised because, a cheaper oil versus subsidizing healthcare. I mean, I think there's a lot of education that's still needed. And using an app, I think if it even at a very low bar raises awareness and being more conscious of dietary intake, I think is already a win. Over time, it's very obvious the apps will improve, right? As they garner more data and the models are refined, it's going to improve. I don't know yet which apps might be the very best at being right on the dot. I don't think there is one yet, but at the very least, I think they're raising awareness. Now, after that is adherence. Okay, I think that I have used apps before, not for food logging, but for fitness logging. And I was really into it. And I think about 3 months in, I just kind of stopped. right? And so what I do now, actually for those interested, what I do now with my food is I do enjoy snapping photos of food, as I'm sure probably many people out there do. And just to keep things as simple as possible, I will sometimes kind of take a screen capture of a mosaic of food and send it through a color analyzer. Okay, and it's not scientific, but for me, I like it to trend green. Okay, I like it to trend green. If it starts to trend like brown, which means I'm like maybe consuming too much red meat or something like that, I kind of wake myself up a little bit. All right, so I try to find little tricks that maybe down the road can be built into some sort of scalable app. But raising awareness, education, adherence, I think the apps still have a role in driving that.
Thank you. And the second question is quite simple. So for your cured AI optimization, have you ever had any work on the tyrosine kinase inhibitors before?
Not yet. We were approached by a number of lung cancer clinicians, and one reason they liked it is because there's so many different dosing increments that you can do with the TKIs, and so I think it's a matter of time.
I see. All right. So the third question would be that what's your theoretical understanding of how less dose might sometimes prove more effective than higher dose in reducing these tumors?
It's a good question. There's a couple ways that we've seen. One is synergy. Okay, but synergy is a very popular term, whether it's supplements, drugs, et cetera. And synergy can be important. There's now new bodies of work showing that under certain cases, it can be antagonism that actually helps better outcomes. But I will say this, no matter what the drugs are, which is better under what circumstance, synergy is dynamic. Just like people are dynamic, so is synergy. Synergy is we've shown, is dose dependent and it's time dependent and it can be patient specific. So just because a combo that is, whether it's FDA cleared or whether it's well established, is given to a person, it doesn't mean it's actually ever synergistic for everybody, right? So when doses are changed, it really, we can visualize it, right? Because we have the avatars, we can see how we are sometimes reacquiring synergy, where it's not a situation where the person's not responsive anymore. It's actually a reacquisition of synergy. Of course, the immune system matters too, right? And so we do know that when we think about combination therapy, sometimes we think only of the drugs, but the immune system is part of that combination. And depleting that certainly has its major drawbacks as well. And that's one of the reasons why we think it's happening.
I see. Thank you. And the next question would be that what's your greatest metabolic proof that one meal a day and fasting contribute to your longevity? Not right now.
The simplest answer to that is I actually don't know. I have no answer for that. What I do know is that, and by the way, my OMAD is not, so, you know, I have an eating window, and this is for me, and I've actually had discussions with people who do this. My eating window is anywhere from 2 to 4 to say 6 hours, generally speaking. I kind of fluctuate all the way out there, 18:6, 24, maybe 22:2, but not super often. Yes, in some cases to re-equilibrate out the schedule, I go 24. But I don't eat like one small meal per day. That's actually not how I eat. When since maybe the photos don't do it justice, the salad that I eat is in a massive salad bowl, right? And then the chicken that I eat is a fair amount of chicken. I consume multivitamins, prebiotics, probiotics. I do Greek yogurt, chia seed. It works for me. I do consume a fair amount of seeds in the salad, or seeds, pecans, other veggies, all of the above. Olive oil, some salt, etc. I used to kind of sit there with a bunch of food in front of me and just eat it all at once. Right. I actually don't do that anymore because it can cause indigestion. I felt that I was speed eating when that happened. So I've kind of really gained some discipline in the duration that I use to consume the food. And I actually think that plays a role, right? Because if I'm speed eating it all, I don't finish it. And if I don't finish it, anything from not taking in enough calories to certainly, you know, under eating, right? That's not where I want to be. So whether I know or not, I don't. But what I do know is that, and maybe I don't doubt that if I stretch out my eating, maybe the outcomes will be the same, but my performance improvements are pretty substantial. I'm reaching some numbers that put me in like 99th percentile for like 25-year-olds for whether it's push up or grip strength or whatever. So it's so far I'm doing okay, and I find it sustainable for me. And frankly speaking, part of it is a mental exercise for me. To know that I can and by the way, I'm not suffering ever. I'm not suffering right now. I'm having a great time. Because we want to keep it healthy, we want to keep it safe. But so far, when I break the fast, I don't become some sort of like beast that goes to McDonald's like for doubles and triple helpings, right? I'm able to kind of manage the discipline, and that's a part of it too for me.
All right, thank you. And the next question would be like, have you ever tested your epigenetic age using any of the clocks?
Haven't done it yet, and I'm very excited to do it. We know we have some outstanding clinics where we can do this, and so that's a simple one too. It's just a matter of time. I'm very excited to do this soon, and I'll probably try to do it longitudinally.
And you should measure your microbiome if you haven't done so yet.
Yes, I was just at a dinner yesterday with people who are active in that space. And there's more and more literature coming out about fasting and its role in microbiome. And something I didn't mention yet that I want to mention now is, much like we think about combination therapy for pharmacologics, it's important that I don't want today to be mistaken as like the fasting talk, right? Like fasting is a part of what I do, but so is trying to make sure that I eat healthy food. And part of it is to make sure that the food that I eat is also supportive of the microbiome. It's not that I fast and then everything else is an afterthought. It's not that I fast and lift weights and everything else is an afterthought, right? I think that I think sometimes it's easy to see one term and be like, it's the fasting guy. But I want everybody to know that some people shouldn't fast at all, right? I want to be very clear. Some people shouldn't fast at all. Some people maybe can focus on nutritional intervention and to each their own in terms of what fitness regimen they have. Our whole thing is about combinations, right? It's about being comprehensive. It's about being balanced, right? And that's why, like, there are days where I'm like, you know what? I did 7,000. Actually, this is true. I did 7,000 push-ups 2 weeks ago. 1,000 a day, and I tracked time to completion, how many continuous push-ups I could do. During those weeks, my dietary intervention changes, right? I'm not going to be like fasting. Okay. I'm not going to be fasting heavily and doing 48-hour fast during those weeks. We know ourselves the best. It's a multi-pronged approach. And we have to know our best in terms of, sometimes we're like, look, today I'm going to maybe go out to 2 meals, 18-6, to sustain the effort, because it's not just about fasting, it's about fitness as well. Addressing sarcopenia, strength training, all has to be sustainable.
Get to know yourself and then act.
Yes.
Over to you, Anne, again for the next question.
So the next question is that, so now there are many health applications and wearable devices in the market now. So how do you recommend patients which one to use?
I don't. So I'm going to start things off with, I am not a licensed medical practitioner, but for myself, what I can say is I've enjoyed using them. I've enjoyed, so, health apps, there's a lot. And there's, systematic reviews that are out there and more on the way that will kind of help to decipher which ones are evidence-based and which ones are not. And I think it's important for people to do that evaluation, that assessment before they undertake something. Fortunately, a lot of these systematic reviews are open access, right? So I think it's important to kind of stratify that way for the apps. When it comes to the wearables, I'll tell you this. I've actually been surprised to learn about who hasn't tried yet. Not judging. I'm just like, oh, it's really interesting to see who hasn't tried, who has tried, who will try. And this is what I do think. I think that for those who haven't tried, say, CGM as an example, you may be surprised at how interested you become in your own data. And what that interest looks like will be different from different people. Some people will be like, oh my gosh, I did not realize that carbs did this to me, I'm going to start reducing carbs. Some people will gamify it. It'd be like, my goal is to never go above 6 millimole per liter, today. Some people don't consume a lot of carbs. And then what's going to happen is, like me, they're going to go lift weights and be like, wait a minute, what's going on? My glucose just shot up from weightlifting. I'd be like, oh, I didn't realize that glycogen depletion was so rapidly recordable by a wearable. And by the way, over time, that spike decreases as you deplete continuously and then switch into ketosis, right? And so some people will see from these devices that foods that they thought might be spiking their blood glucose maybe don't. And then finally, there are some people who will say like, oh, my blood sugar is so low in the afternoon, I'm hypoglycemic, it's really bad. And then they'll look at the wearable and realize, you know what, my blood glucose is totally fine, right? I will add that I've used various wearables. Some of them do need some calibration. And that's why I still use the blood collection. Remember, interstitial fluid for this, blood for that. I do both just to see how well aligned they are.
The next question will be, for the ketone profiles that you mentioned in your presentation, can you calibrate an overall optimal range for the Asians? And is it possible that in the future, these medical devices can use it by using the broader indicators instead of using the granular data collections? What do you think?
It's a good question. I don't know if there's so first of all, back to something I mentioned earlier. For those who are diabetic and pre-diabetic, definitely have to consult a physician, because uncontrolled ketone levels can actually be life-threatening. Okay, you've got to remember that. And so for those who have never done this and who may not be aware of their respective profiles, it's always important to speak to a clinician first. When it comes to optimal ketone levels for Asians, I don't know if the data is there. But what I do is I look at things like GKI, right? Your glucose ketone index, which can also add some other insights into kind of the broader health status. I look at that for reasons too, just to also make sure that I'm not so ketone high and so glucose low that maybe I'm driving myself a little too hard. I don't have enough data to derive population level conclusions. And furthermore, I am quite dynamic, right? I'm quite dynamic in terms of if I were to eat, I'm sure if I were to eat exactly the same amount of chicken today with exactly the same amount of greens, measure out the olive oils, etc., look at my ketones, I'm going to be dynamic, right? So it's a bit more of the general levels. If you're above 0.5, if your GKI is in a certain range, maybe you're in a deeper ketosis. We're still not so absolute that 2.6 is the goal you want to reach for. 2.6 for somebody could be okay. 2.6 for another person, they may end up with kidney stones, right? So it's there's things we have to pay attention to.
Thank you, Dean. This was really wonderful. Really an advocate for the new field of medicine, to really look at the physiology and look at the determinants, the interventions, and again, at the outcomes. Thank you so much. Very inspiring. As I said in the beginning, you're a very inspiring personality and person. Okay.
Thank you so much for having me.
Thank you so much. There are a couple of tickets left for the Unlock Healthy Longevity Supplements Conference. That's the conference we have at the 29th of February and the 1st of March 2024 at the Yonglun Lin School of Medicine at the NUS. It's the first global scientific conference focused solely on the role of supplements as a geroprotective intervention to manipulate the physiology and to manipulate the biological age of humans. Mark also another event in your calendar, and that's on Saturday, March the 2nd. That's our special day, really dedicated again for supplements. It's an open day for the public, and you can find more information in the chat box, but also in the QR code. There are a couple of seats also left, but be quick to get your seat. The next episode is on the 15th of February. I will welcome Dr. David Barzilai from aging.com, and he will talk about the future of health, and that's longevity medicine, of course. We will close the meeting with a video. I would describe it as habits start in the morning and continue during the day. Take care.
I'm feeling like sunshine, like springtime, like something's in the water and I'm taking a deep dive. I'm feeling so weightless, like I'm gonna make it, and nothing in the universe can take this. I can see it clearly now, nothing gonna bring me down.